Hello, this is Joshua Smith, and this is my presentation for Social Work 523, Rural and Urban Social Work. And the title of my presentation is Opioid Epidemic, a Rural Perspective. And we'll be talking about a topic that is really important to me as having experienced substance use disorder and wanting to work in the field. That's why I'm pursuing my master's in social work. So, without further ado, let's learn about the opioid epidemic in rural communities. First, I'm going to be taking a systems theory approach. Systems theory basically it's taking into account many factors when describing an individual or a community's experience with a certain issue. In this case, that will be the opioid epidemic and substance use disorder. Taking in multiple factors helps us better understand what goes into creating the problem and what our options for solutions might be as far as addressing the problem. Systems theory emphasizes that the whole is greater than the sum of its parts, and individuals cannot be understood in isolation, and neither can communities. So we're not going to be talking about individuals so much today, though the opioid epidemic impacts individuals and their families at a very alarming rate. So the United States has been enduring the scourge of an opioid epidemic that began in the late 20th century, and it continues on to this day and has only grown over the last 25 plus years. There are three phases of the opioid crisis. The first phase began in the mid 90s. It's when a drug called OxyContin came out and really kicked off a new craze in pharmaceutical prescribing because the manufacturers said that there was low potential for abuse and addiction to the drug and that it was safe to prescribe at ever increasing amounts to the population. This also signified uh, an increase in doctors addressing people's pain specifically, rather than sometimes the underlying conditions that cause the pain. So rather than heal the person, we just want to kill the pain, and this led to an increase in opioid prescriptions nationwide. The second wave began in about 2010. New drug enforcement regulations severely limited people's ability to do what was called doctor shopping, and in which they would go to different people were getting more and more dependent on these painkillers because, unlike what the drug manufacturer said, they are addictive and create significant substance use disorder. So people were going to various doctors seeking ever larger prescriptions. And what the Drug Enforcement Agency did was make it so that pharmacies communicated not only within the state but nationwide, so that they could notice if people were filling multiple opioid prescriptions in different areas. It used to be that you could just run around getting these prescriptions from anywhere. There were doctors that were overprescribing all over the place, particularly in rural areas in the South, and in sort of the Mid East region, like West Virginia, Kentucky, a lot of places that were heavy in manual labor and industrial enterprises. So what happened in phase two was that people became more dependent on heroin because and street drugs because they could not get their hands on as many opioid pills. Then phase three began. That's the phase we're in now, and I'm sure we've all heard about an incredible uptick in overdose deaths due to the introduction of fentanyl and other even more powerful synthetic opioids into the drug marketplace. So basically, what's happened is substance use disorder in the population has only increased, while the access to comparatively safer drugs like the prescription drugs has decreased. So people are seeking out more and more street drugs, and this has created a increase in heroin and then now fentanyl in the streets, which is cheaper, more powerful, and certainly more dangerous. And overdose deaths have spiked dramatically, as we'll see in this next slide. This shows the three phases. You got phase one, prescriptions; phase two, heroin started increasing overdoses, and then you see this incredible spike in opioid related deaths. And that was in fentanyl, carfentanil. Then there's a new one that just started showing up on the streets called cyclorphine, that actually killed 16 people in East Tennessee since late last year, that is starting to show up in the drug supply. So that's really scary. And it's something that, as we're going to see, really affects rural communities as well as urban communities, but the effects on rural communities can be devastating due to some of the factors that they experience. This is a map of the counties that have some of the highest number of opioid pills prescribed per person. This was 2006 through 2012. You'll notice, like I said, these darker areas are, so you got West Virginia and Kentucky right here, Tennessee. Here's good old Alabama, and I believe this is Walker County, this deep red, that has an incredible amount of uh, opioid prescriptions, opioid pills prescribed per person. When you get into this dark red, that means there's 150 plus pills prescribed per person every year in that county. So you got to imagine not every person is prescribed to these. So there's people that are getting hundreds and thousands of these pills a year to make it that many per person in one county. So, according to the latest data available, people living in rural areas use opioids at a higher rate than those living in metropolitan areas, and even higher rates in completely rural areas, as opposed to kind of mixed urban and rural areas. And a 50-year retrospective analysis shows of heroin users that there were 90% white, equally male and female, started around the age of 23, and 75% of them were introduced through prescription drugs and lived in mixed rural communities. So, as we could tell, since 75% are introduced to heroin and then eventually stronger opioids through an initial contact with prescription drugs, access to these prescription drugs is a huge problem. Prescribing rates for opioids are up to sevenfold higher in rural areas compared with urban ones. And heading that list was Alabama's 4th district, where doctors wrote an astounding almost 167 opioid prescriptions per 100 people. So that means there are in that district, in the 4th district of Alabama, there are people getting multiple opioid prescriptions to make it so that there's over one per person in that area. Previous studies have found that this disparity in opioid use is linked to greater prescribing, which we can see there's much higher prescribing in these rural areas, and that the odds that a patient in a non-metropolitan area is prescribed to an opioid is up to 50% higher than it is for a patient in an urban area. So rural doctors are prescribing opioids more frequently and in larger prescriptions than in urban areas. Um, and the result of this is there's higher levels of higher mortality rates for people using opioids, as seen earlier when introduced to the opioids pharmaceutically. It's not long before, once that supply runs out, individuals seek out heroin and synthetic opioids in order to satisfy their substance use disorder. This is just another graphic showing the drug overdose death rate, and but the kilograms of opioid pain reliever sold per 10,000. And you'll see some of these bigger circles are in those areas we talked about, the southeast, the eastern, mid-eastern area, and then of course these darker areas are the highest overdose death rates, which correspond quite frequently with these larger yellow circles. The impact is that in rural areas, rural residents have higher rates of overdose deaths, suicide, depression, babies exposed to opioids in utero, and of course, increased transmissions of diseases often associated with intravenous drug use, like HIV and hepatitis C. To speak to the systems theory, this pervasive opioid use undermines rural values of family unity, closeness, and belonging, as well as economic security. Children living in families that where the parents or siblings are using opioids are more likely to suffer neglect, abuse, chronic stress, and trauma, all adverse childhood experiences. And then having adverse child experiences is highly correlated with being having substance use disorder later in life. So it's a vicious cycle of those who grow up in that kind of environment are more likely to end up perpetuating the cycle and becoming uh, heavy drug and opioid users themselves. Barriers to treatment. 2.8 million people in non-metropolitan or rural areas in 2020 met the diagnosis for substance use disorder, yet only 10% of those receive substance use treatment from inpatient or outpatient services. Um, and only 1 in 500 receive medication for opioid use disorder. It's estimated that 90% of treatment programs and medically assisted treatment providers are located in urban areas, so this is a huge barrier to recovery for people in rural areas because they don't have that nearby access to it. They have to, if they even decide to seek treatment, they have to travel to an urban area to receive it. Um, Other relevant barriers to treatment are, fear of withdrawal. All opioid users experience that. Close-knit communities in rural areas make people afraid to seek treatment sometimes because they know their confidentiality is hard to maintain because everybody knows each other in a small town. Um, when opioid use and substance use disorder is pervasive, it seems like everybody's doing it. Like you can't get away from it in a small town if everybody around you is also doing the same thing. And then, of course, the stigma of not only using the drugs, but if everybody around you is using it, the stigma of getting off the drugs. There's actually a reverse stigma there. Organizationally, treatment programs are managed punitively. There's lack of gender-specific treatment. People are worried about losing their jobs. Jobs are a huge factor in rural areas. They're not as easy to come by, and they're often require manual physical labor, which people get injuries and they get on the opiates and they need to keep taking them in order to perform their job. Um, and then, like we mentioned earlier, there's just limited availability to treatment in rural communities, lots of transportation, wait lists, and lack of education about treatment options. Uh, the Rural Communities Opioid Response Program is a federal program that is trying to get money and grants to rural communities in order to improve access to treatment. Of course, they seek to reduce deaths from opioid use disorder and other substance use disorder in rural areas by increasing access to prevention, treatment, and recovery services. Uh, our Corps provides planning grants that support rural communities by conducting needs assessment and connecting interested organizations in order so they can work together to develop plans for sustainable service. And it also provides implementation grants for services that may already exist in order to strengthen their substance use services. And then these grant applicants, it's wide open. They're really trying to get more money and more programs into these rural communities. So it could be nonprofit, for profit, private, public, and it could also be evidence based or innovative approaches to the opioid and substance use issue. Anybody can apply to this grant that is serious about addressing the problem in rural communities. National policies are there's the Mental Health Parity and Addiction Act of 2008, which was huge in, if you're my age, you remember insurances used to not cover mental health services very well. You could break your leg, get open heart surgery, your insurance would cover that, no problem. But if you tried to go to see a therapist or to a rehabilitation center, there's a good chance insurance may not cover those kind of treatments. What this act did was make it so larger insurers, most insurers, have to cover mental health treatment and rehabilitative services for substance use disorder, just as if it was a physical ailment or a medical condition. And then the Comprehensive Addiction and Recovery Act of 2016 was huge. It authorized funding. This funding is renewed annually by Congress, but it's to support prevention, treatment, recovery, law enforcement, criminal justice reform, and overdose reversal. And the good news is it's a major shift away from treating substance use disorder typically in a punitive manner, whereby the person suffering is locked up or stigmatized or not treated in such a way that they're encouraged to look for help. This legislation actually shifts our money and our focus toward a more public health and a more compassionate approach in order to solve substance use disorder and um, the opioid epidemic in America and in rural communities. Here are my references, and thank you so much for your time. I hope you all have a wonderful spring break.